that people
Yeah.
are just staying in the pool. It's crazy.
I think I'll get started. Thank you all for coming to the Department of Epidemiology seminar series. I'm very, very pleased to introduce Dr. Jon Andrus. Jon actually has an adjunct appointment here in epidemiology, but also in family medicine and pediatrics. He's officially located in Washington, D.C., but he leads the University of Colorado's efforts to advocate for the evidence-based use of life-saving vaccines around the world. Dr. Andrus has served as Deputy Director at the Pan American Health Organization. He's also held positions at the CDC in their Global Immunization Division. And he is currently co-chair of the Global Polio Partners Group and has numerous WHO committees. Oh, am I not talking into the mic? Sorry about that. Okay. Committees, and so he's very, oh yeah, now I can hear it, very active in this role, and I'm very much looking forward to what he has to say regarding this real-world experience. Jon?
Thank you, Jill. It's a pleasure and honor to be here. I've been asked to talk about evidence and advocacy for immunization in developing countries, and I'd like to do so looking through the lens of my 22 years of working for the World Health Organization, most of that time as a CDC epidemiologist seconded to WHO, and the last 15 years of which were at the Pan American Health Organization. So, in a former life, my first overseas assignment was to Malawi, working as a Peace Corps volunteer. I was assigned to the Machinji district, where I was told I was in charge of all preventative and curative health services, and I was asked to run the 66-bed district hospital in the village of Machinji. It also served 12 outlying bush clinics throughout the district, and measles was a big killer there. As you may know, measles in Latin means miserable, and this child is certainly miserable. Those with a clinical background may notice other potential complications with this particular child: the receding hairline, the reddish tint to the hair, suggesting vitamin A deficiency, putting this child at enormous risk for serious consequences of measles, some 23-24% increased risk of mortality, and other associated sequelae such as pneumonia or blindness. So that was my first exposure overseas. I got to see firsthand the efforts that occurred as a result of the 1986 Africa Year of Immunization, and which was an influx of resources, largely led by James Grant at the time, who was the director of UNICEF for the Universal Immunization Program, with the target of reaching 80% coverage in all developing countries by the year 1990. And that year, it was recognized Malawi had only 20% coverage for most of its antigens or less. And we had a measles ward. If you can imagine that in this hospital, one ward dedicated to measles. And all the beds were full, usually 2 to 3 children per bed. So it was my first taste of the power of vaccines and immunization to prevent this. And I got to see firsthand with this bolus of resources, the training, the empowerment of the health staff to prevent what they were seeing, the deaths usually on a daily basis during the epidemics. So I decided at that time I wanted more of that, and hence my career. And I think I could say that 1987 was the last time I wore a stethoscope, and I've been fortunate. Never looked back, and I've been very fortunate to share some of the experiences in this talk. The milestones in the Americas, in the PAHO countries, are summarized here. I have to recognize that most of this is due to the efforts of Ciro de Quadros, who was the grandfather of the expanded program on the immunization going back to 1979, and I had the opportunity to work with Ciro. I always call him my guru. And I won't go into the details, but from the creation to the revolving fund that coupled vaccine supply logistics with the technical strategies, and then the milestones of the eradication of polio, an opportunity that I had the fortunate experience to be involved with under the leadership of Ciro, and then subsequently to work on measles and rubella elimination, leading to more advocacy work, such as the first vaccine week of the Americas that later became the Global Immunization Week in America. So you can see, I hope to give you a sense that in the Americas there was amazing opportunities to use evidence and advocacy, and I'll always mention advocacy in this talk, that leads to action. Because it's one thing to communicate, but if you use the science, the evidence, communicate it, and then leads to action, that's the kind of advocacy we like to see happen. This graphic summarizes through a different lens some of the elements of that progress. You see on the left the various elements that include the number of vaccines that many countries have in their national immunization programs compared to 1977 to the current year, or the doses per child, or the target population, the number of children less than 1 year, or the including the cost per vaccinated child, and then the evolution of the program itself. And you see amazing progress going from 6 vaccines to 20 vaccines, 10 doses per child to in some countries 20 doses per child, a target population that is now 15 million children less than 1 in the region, and at a cost of $70 per child. So in a way, these are amazing milestones, but we're victims of our success, largely because of the cost, number of vaccines, and some of the pushback, either from parents or from ministers of health, ministers of finance, towards the benefits of immunization. And fortunately, we're evolving from a strong foundation of a childhood immunization program to an immunization program that involves the life course and the opportunities that life-saving vaccines have for the benefit of a person throughout its lifespan. In the case of cervical cancer, 80% of the deaths occur in developing countries. So vaccinating young girls to prevent cervical cancer is a benefit of a benefit of a life course approach. Now, as we have become victims of our success, having this additional evidence, I'll use the example of some of the data coming out of this particular study that was in a special issue of Health Affairs that provided data on the return of investment for immunization programs in middle and low middle income countries. This return on investment is an idea that most folks can understand, particularly those that are not necessarily grounded in science or technical background. For example, a minister of finance, and oftentimes the political appointee, a minister of health. So the net benefits gained from every dollar, Senora Ministra, that you spend on your program. These are very powerful arguments going forward, and I think has helped. The methods for estimating the return of investment include sort of the cost of illness approach, focused on the health system, cost of hospitalization, or a full income approach, what we call a societal approach. The work days or the other costs associated when looking at a societal approach. And the results are summarized here. Very succinct message is that if you invest $1, you may save $16 in health services costs. But if you include those other benefits that a family may benefit from, then it goes up to $44. Quite a return on investment. And one of the things that comes out of this is it would have been a year ago, January, at a ministerial meeting in Addis Ababa at the African Union. There's a beautiful building there for conferences, and all the ministers of health and all the ministers of finance were there, and these data were presented. At the end of that meeting, these ministers signed off on a declaration that they needed to invest in immunization. So what better way to use evidence to promote and advocate and end up with a declaration? Now, does that translate to more kids getting vaccinated? That's another story, and we hope it does. But in that continuum, these kind of data have helped. Now, I'm going to use the example of polio as a case study and illustrate how data such as these had led in the Americas a tremendous value added to getting ministers to decide that polio was eradicable, it was possible, and until Brazil, the largest country in the region, was able to do this and show that results could be attained, then the smaller countries, with also challenges, that was really convincing evidence in the Americas. We use data to understand better the risk of the oral polio vaccine. Some of you may have remembered the debates that went on which antigen to use, whether the oral polio vaccine or the killed injectable vaccine should be used for eradication. That's not the purpose of this talk. I wanted to illustrate for you, though, using the surveillance data, the data that countries reported from the most peripheral health units on investigating cases of acute flaccid paralysis to the state, national, and regional level in PAHO, Washington, D.C., we were able to analyze this data and determine the risk of the oral polio vaccine because we were using that to stop transmission. And it's still the vaccine of choice to stop actual transmission of polio virus. And the thought was perhaps this risk of vaccine-associated paralytic poliomyelitis was higher in countries like Mexico, Brazil, Latin America than it was and had been published for the United States, Canada, and Europe. And our study showed that it was comparable. You'll see on the right the number of cases of VAP. We use that acronym, vaccine-associated paralytic poliomyelitis, according to the variants in case definitions used to do the analysis that you see in the column on the left. And so we were able to show that it ranged most likely between 1.5 cases and 2.2 cases per 1 million doses administered. And again, this was comparable to experience in North American countries and European countries. So important evidence that allowed us to mitigate the backlash of anyone that would say don't use oral polio vaccine. We also generated evidence because the question was, is acute flaccid paralysis is it sufficient to determine that you've eradicated polio? Something else needs to be done? Is it sufficiently sensitive, specific? we monitored sensitivity and specificity of acute flaccid paralysis surveillance using the AFP reporting rates that we call. They're rates that if you achieve 1 per 100,000, it's comparable to the data we were seeing with Guillain-Barré syndrome. And Guillain-Barré syndrome is one cause of polio. So if you got at least 1 per 100,000, that was suggested that you would probably capture all polio cases, those AFP cases caused by the wild virus. And then for specificity, when those cases were reported and investigated, we would collect stools to determine indeed and be able to answer the question, was wild virus causing this? And that's where specificity. But certain people question, was this going, we were learning as we were going. No one had ever tried to eradicate this disease. So the idea was that perhaps an adjuvant, some supplement to AFP surveillance would benefit the program. And so hence we tested detection of wild poliovirus in the sewage. And the map shows the canals, parallel canals, going through this village in the slums of Cartagena. And the picture doesn't come out very well, but you'll see the degree of poverty and that you can get a glimpse of what looks like water, which is a canal going between the homes. And I distinctly remember children playing soccer with the ball going into the water and continuing to play. This was a breeding ground for polio. And we picked up virus and we were able to show that it would supplement, but we found that the AFP surveillance was sufficient quality that we didn't have to put a lot of our resources into this type of surveillance. So we made a programmatic decision. Yes, it's nice, but we're not going to put limited resources to include this. It's a different story today because in Pakistan and in Afghanistan, there are areas where you cannot reach, and so you would like to use anything you have available to see if there's wild virus, and that would be a different situation. But we were able to conduct some of the first studies. And indeed, the strategies we were able to show worked. And this is Luis, the last case with the date of onset, August 23rd, 1991, and later certified free of the region of polio. And his mother is on the left, and that is the National Immunization Manager on the right. So we learned that acute flaccid paralysis surveillance was critical, but its management and oversight was even more important to sustain and achieve the kind of quality of surveillance that you needed, that the data collected was complete, that it was high quality, you could use it in analyses, and you could use it to determine when you have reached the target, or where there were problem areas that you needed to do other interventions. The network of the polio labs was also fundamental with the specificity I managed, and the protocol for determining that polio was certified was developed by the team, and we had a better understanding of risk, as I mentioned. We learned that it was critical to sustain the gains. And to this day, there's still countries in Latin America that do national immunization days to, in those very hard communities, maintain population immunity that would protect them if there were any importations. This is an important lesson that we haven't quite taken fully advantage of globally. And then capacity development. Cyril, in his genius, I don't know, many of you may remember Carl Taylor. He's no longer with us, but during this time, he was the world's leading expert on primary care in developing countries. Carl Taylor was not a fan of eradication. So what does Cyril do? He hires Carl Taylor to lead this commission to evaluate whether polio impacts either negatively or positively health systems. And you see the findings that created a culture of prevention, increased community awareness. That is fundamental in public health, to get the community awareness, and beyond that, engagement and ownership. and then the multi-sectoral collaboration. Now, trying to use the experience and going, expanding that to other parts of the world, I went off to India, where I worked from 1993 to 2000. And remember, 2000 was the global target. We were bound and determined to reach that global target. And there was not one country in Southeast Asia that had even adequate surveillance, let alone the immunization strategies. Now, India at that time consistently reported about 2/3 of the world's population, 2/3 of the world's polio cases. So it was a challenge to get countries like India, Bangladesh, Nepal, Myanmar, Thailand even, Indonesia, to do the necessary strategies. But this was the calling card, using the experience of Brazil and coupling that with the need to have community involvement, partnerships, and ownership. And I think this photograph embodies much of that. The woman you see giving the drops is from the community, and she's a Rotarian. So partnerships. And the nice thing about Rotary is that although they donated money, they were also actively engaged in the action. So all fundamental components leading to success. I'm going to show you evidence that really provides insight as to the power of oral polio vaccine. That's the trivalent vaccine that includes all three polio types, 1, 2, and 3, in a ratio that's 10-1-6. Orissa, as you see in this map, is one of the 8 poorest states in India. The 8 poorest states in India are the northern states, largely bordering the Ganges River Valley. And you see by the red dots that Orissa had, although not as much as, let me see if I can use the pointer here, of Bihar and Uttar Pradesh, Bihar, certainly had its share of polio. I don't think I've ever worked with a more competent and committed minister of health than the woman that was in charge of Orissa. I explained to her that we needed to do more expansive campaigns to further limit this transmission. In the Americas, when we did mopping up, that other strategy at the end where you go house to house, where the virus has now geographically restricted itself because of your vaccination strategies of the National Immunization Day and good routine, that you could come in with that knockout blow, as we did in northern Colombia, Peru with the last case, Central America. Edwin is sitting in the audience, Dr. Asturias, and he was a key player in that. So she decided, though, no, I think we can do it. And she went after these cases in her state, and the target population was about 1.7 million. And the end of the story was she did it with her team, able to go house to house and stop transmission with this mopping up. And it really was a lesson for the rest of the country, and Bihar and Uttar Pradesh fortunately took that up, and they also eventually became polio free. So my point is, the evidence showed that when you do the interventions with high quality, reaching every child, you can interrupt transmission in the most difficult circumstances, leading to 0 cases here. So some of the key points leading to where we were in 2000, we had successfully mobilized the resources that would allow the interventions to be conducted in the 5 high priority countries of India, Bangladesh, Nepal, Myanmar, and Thailand, and Indonesia. And those countries are listed there. 0 polio cases by 2000, with the creation of high-quality surveillance and the lowest levels of transmission in India in 2000, 264 cases. In the year 2000, 264 cases, an all-time low. Now, there were still some doubters of whether or not the oral polio vaccine would be sufficient to reach the final target in the most difficult areas of India and elsewhere. These are data showing the immunogenicity of monovalent OPV versus trivalent OPV in Egypt, you see on the left, and India on the right, comparing in light blue the trivalent OPV and the results of the monovalent. In Egypt, it was 1 dose. In India, it was 2 doses. But the comparison is pretty clear. The monovalent works better. We knew that. It does work better. But the question is, do you use this evidence to make a major change in your program strategies? In hindsight, the answer is no. But at that time, it was decided, and when the monovalent vaccine was introduced in a sequential doing type 1 monovalent, type 3 monovalent later, in between, you would have outbreaks of type 1 and type 3 because the susceptibles accumulate. So it was a decision we wish we could take back. And it set the global program back probably 10 years. The combination of this, as well as in India, to diminish the number of rounds that we had been using up until 2000, which was a 4+2 strategy. 4 rounds over the whole country in 1 year, plus 2 additional rounds in Uttar Pradesh and Bihar, the 2 most difficult states. And that knocked down transmission substantially. In 2001, they decided, because it looked like great progress was being made, let's decrease the number of rounds. And as a result, in 2002, there was an outbreak of 16,000 children with paralysis in Uttar Pradesh in 2002. And this, coupled with this, the world also suffered, not just India, because there were exportations. And you see, as a result, the summary of what happened from 2003 to 2009. So again, setting the program back almost 10 years. And many of the partners became fatigued, questioning whether it was going to be achieved. Fortunately, Bill Gates, largely convinced by Bill Fahey, who is his senior advisor, convinced Bill Gates that it could be done. It just needed the resources. So going forward, we've always felt we had the opportunity to build on polio and prevent the measles and measles-related deaths. The recent years, measles is no longer in the top 5 of the killers of children less than 1 or less than 5. But it still causes 100,000 deaths that are totally preventable. So even though it's not in the top 5, it might be 6, 7, but it still causes 100,000 deaths, and that's an opportunity to make a difference. We still have congenital rubella syndrome. This year, India is introducing the rubella-containing vaccine. So unfortunately, unlike the Americas, many of these large countries like India, Indonesia, and Philippines have yet to introduce the rubella-containing vaccine. And we estimate that 110,000 CRS cases occur every year, totally preventable, and then the opportunity to introduce new life-saving vaccines. I'd like to spend a little bit of time on measles and rubella, and I think many of us are involved with the measles rubella elimination because of the opportunity to prevent congenital rubella syndrome. Like polio, this devastates families impoverished. You can imagine a child born with this syndrome, the life ahead. So the textbook describes this classic triad of microcephaly, cardiac defects, and cataracts. But in actuality, there are a lot of other consequences to intrauterine infection with this virus that includes mental retardation, behavioral abnormalities, even autism. CRS causes autism. I wish Andrew Wakefield acknowledged that, as opposed to trying to justify that the vaccine causes autism. We're still suffering from that article published some 15 years ago. But my point is that whatever estimate we have, it's probably underestimated. And this is a terrible disease that is, again, totally preventable. Dear friend and colleague Lou Cooper provided this slide for me. Lou is actually probably the grandfather of the epidemiology of congenital rubella syndrome. He was in New York in the 60s when the outbreaks occurred during that time, and still actively engaged. Amazing man. So you may recall that congenital rubella syndrome, aside from the photograph I showed with the triad, it can affect all organs. Children can be born with significant metabolic defects, including thrombocytopenia. It can cause intrauterine death. Again, hard to determine the cause, so again, underreported. If a mother is infected in the first 10 weeks of pregnancy, the risk of that infant, if she's susceptible, the risk of that infant developing CRS is 90%. So formidable. If it's the first trimester, 85% by most estimates. Just some data to show the disease burden globally, 110,000 cases per year that I mentioned. These are old data, but the situation has not changed. In fact, with our better understanding of the underreporting, the numbers are actually higher. The children born with CRS can excrete the virus up to 1 year. So this evidence is important to ensure that families protect the child or keep the child from spreading the virus to other susceptible children by keeping it in the household and not under total isolation, but it's important to prevent transmission, knowing the child is excreting the virus up for almost a year in some cases. The data speak for themselves. The strategies with the campaigns, I won't go into the details. I want to leave some time for questions, but you're basically talking for measles, a combined measles rubella vaccination of all children less than 15 years of age in the country. It's a one-time campaign. And then every 4 years, you do what's called a follow-up campaign, targeting with the combined measles rubella vaccine, targeting children less than 5. So the first one that starts the program is the less than 15, then followed every 4 years, less than 5. Very different from polio. I wish we'd started with this before polio. But Cyril was quite a mover, and he convinced people that the world should embark on polio, when indeed, in my experience, it's easier to eliminate measles because you have time to develop people. You have time to plan for those campaigns. You have time to develop the quality and the surveillance. And most importantly, higher coverage in the routine immunization program. So then 4 years, it's time to do, and you plan for it at least 6 months in advance, and it takes a country, 4 to 6 weeks to conduct. So for reasons that I mentioned, very feasible, and the data speak for themselves. With the cases of measles in red and the cases in blue for rubella. Does anybody know why the blue shows up after measles drops down? Well, this program tested both. Initially, it did not, just tested for measles, rash and fever, and then we test for measles. The entry point in the syndromic reporting was rash and fever. If the negative for measles, okay, we're okay. But they started testing for rubella because that's part of the differential diagnosis, and it was hidden. And when you unearth and start looking for it, you see a substantial disease burden. And fortunately, the strategy includes a combined vaccine, so you get the benefit of both with these strategies. Important data that have now convinced India to embark on measles rubella elimination and the opportunity to eliminate CRS in particular. Now, I'm going to spend the rest of the talk, a few minutes, on the introduction of new vaccines. And this is what we're looking at largely in the past, where countries in yellow are the more industrialized, or green are the more, I apologize, the countries in green represent the more industrialized countries when, during the course of time, they've introduced certain vaccines. And the point is, there's a lag time between when the U.S. introduces a vaccine and a country like Ecuador or Paraguay, developing countries, introduce. That lag time, in the case of hepatitis B, was over 2 decades. And so children are infected. Children, in the case of Haemophilus influenza, die due to meningitis. And same with pneumococcal disease. So that lag time, if we're going to save lives more quickly, we need to get the evidence to generate the justification for taking a policy decision that will reduce the lag time. And that's really the premise going forward. We were fortunate at PAHO to get Bill and Melinda Gates to support the ProVac initiative, which is evidence for new vaccine decision making. And countries told us that they were trying to look at the following vaccines: rotavirus, pneumococcal conjugate vaccine, the HPV vaccine, influenza, those first 4, because those were the diseases they were seeing a lot of burden for which a vaccine was available. And so we then developed the approach to address those initial first 4 vaccines. With the financial support, trying to provide for the decision-making body, it could be the ACIP equivalent in the United States. You're all aware of the ACIP that the CDC uses to formulate policy for immunization. Each country should have that, and they need evidence. They need evidence that's grounded in good science to make a decision. So our role was to help countries collect that evidence. We didn't parachute in, do the study, publish it. We were helping countries generate the evidence, publish it, and make appropriate decisions. And the package listed here, technical, could be vaccine efficacy, for example. It could be disease burden. The programmatic could be the status of the cold chain, because if you're going to introduce a vaccine and your cold chain doesn't have the space for that, you need to buy new materials, for example. You need to train people. You need to do a lot of operational and programmatic things. And then there are also social considerations, how the public accepts it, what is the cost to the country, and the priority to the country. But public acceptance is very, very important. Public perception is important. And the model was to, on the right, at the regional level, have the ProVac team, which was largely, in the early years, Barbara Roegri, and I can't take credit for Barbara's work. I was supposed to be her boss, but she really did the brunt of the work. And then subsequently, Kara Janus, who was also excellent, providing support directly to the National Immunization team, but also to what we created, centers of excellence. So more South-South cooperation, having a university in Columbia, for example, involved with their expertise. And then advising with the evidence package, providing that package to the National Advisory Committee, the ACIP equivalent, that would work with the Ministry of Health for policy change, whether or not to introduce a vaccine. Chile decided not to introduce rotavirus vaccine because they had a very good diarrheal prevention control program. So they felt they could use those resources elsewhere, perhaps with HPV or other new vaccines. So very good process of using the evidence to advocate whether or not to follow a certain path. And the toolkit online provided data in the example of disease burden. Sometimes disease burden, pneumococcal comes to mind. Countries don't have good data, but WHO and partners like the University of Washington have fairly decent estimates that countries can use in the modeling. They wanted help with the cost effectiveness model. They wanted to better understand the value added that this intervention would have. So we focused on helping countries develop those models. For HPV, Sue Goldie of Harvard basically pro bono helped us develop that model. We had support from Oren Levine at Johns Hopkins at the time to help us, and Anashua Sinhe help us with the pneumo model, and Rick Reingans for the rotavirus. So very good networks and teamwork involved to leading to the results I'm going to summarize here, showing the introductions. Now, there were other efforts going on. Countries have their national equivalent of the American Academy of Pediatrics. So those bodies were also advocating. And I think it was a collective effort that led to this kind of outcome where now countries are using these technologies to save more lives more quickly. And we had two special supplements to vaccine. This was one, but we had two that highlighted the country work and particularly of the centers of excellence. And it's always important in global health to share experience, share best practice. It may not be automatically stamped from one country to another, but it helps countries better understand the opportunities they have. They might modify approaches, but publishing, I think, was something we felt would be useful to efforts, and it came out in Spanish as well. So as Cyril used to say, I heard him a number of times, evidence is only as good as how effectively you communicate it, and that was certainly true. So taking a cost effectiveness study and presenting it to a minister, this is how many ICERs or valleys you can save, is not the evidence. They won't understand. So translating that, remember back in the original, the investment case, or if you invest this much, you'll reduce your hospital costs, your treatment costs. There are elements within this approach that you can tease out that serve as better communication messages. And I think that I wanted to mention that that's also an important part of this kind of work. Now, there's also the advocacy that can be done across countries, Vaccination Week in the Americas, I mentioned earlier. And during that week, the United States has participated in every week since it was founded some 12 years ago, something like that, with border activities. I understand Colorado has also been involved, and we hope that that expands. Edwin happens to be on the board, or he's the director of the board of trustees of the Colorado Coalition for Immunization for Children, CCIC, and we hope to expand that engagement with PAHO and other countries, because it's 1 week, the last week of April, where you can use whatever evidence you have on hand, whatever experience, in that 1 week a year to give this visibility. And it helps enormously, whether politically, technically, and it's now Global Immunization Week. And as you know, disease anywhere is disease everywhere, so using these approaches benefits everyone. The opportunity to mitigate risk of importations with the travel has been approached in this way in PAHO before large gatherings, such as the World Soccer Cup, and actually setting up surveillance ahead of time at the site to see if there's a trigger in diarrhea cases, for example, in this stadium. But getting the message out, hopefully teams coming from elsewhere, could be Bangladesh, that their team is vaccinated with the appropriate vaccines before they come. This was a mother we encountered recently. I was on a team of the State Department to visit India to observe firsthand what they're doing with their polio efforts. How are they transitioning those efforts to other immunization activities? I mentioned measles, rubella. They were last year certified as neonatal tetanus free. Imagine, anybody lived or worked in India? Can you, I mean, it's just mind-boggling that they've been able to achieve that as a benefit of polio eradication. And this mother is proudly holding her card of her child there, the vaccination card. This is a brick kiln. So they live in a, you can see there's some bricks there for a wall, but it's corrugated tin for the roof. They get monsoons, they get flooded. It's very poor living conditions. They don't have running water. But she's very proud of the fact that she's protecting her child. And I was very impressed to see that. So with the transition I mentioned, I want to end with a couple of comments, because as David Butler Jones, a former chief medical officer of Canada, once said, it's very simple and it may sound corny to you, but for me, it was 1,000 words because it's like a haiku. Public health is easy to get wrong. It is so easy to get wrong. And Albert Schweitzer said, beware of the future you create for your children. It is true. Whatever action we take today has incredible consequences. And if we take the wrong action and we don't have the evidence, we don't have that decision package, we can do harm. And that's true also for the polio transition. How can we protect the gains but also bridge those resources into other life-saving interventions and activities? And so to put it into perspective, currently the polio eradication initiative is in over 70 countries, but 95% of the personnel this program supports are in these 16 countries highlighted in the color that you see here. And those 16 countries actually have most of the disease burden, where most of the unvaccinated children reside, where most of the measles-related cases and deaths occur, and things like cervical cancer are more likely to happen, and of course, congenital rubella syndrome. So there's a lot riding on getting it right. It's easy to do wrong. And just to highlight what they're currently doing goes well beyond polio. I happen to be on the Global Polio Transition Independent Monitoring Board, which is chaired by Sir Liam Donaldson. Lord Nelson and Sir Liam Donaldson. He chairs the Polio Independent Monitoring Board, so they made him chair of this transition board. Again, it's very complex, very complicated, but hopefully we will get right and do little harm, because at risk, as I have alluded to, are these other programs and initiatives that polio staff are currently providing. And I believe with that, I'll end. Thank you very much for your attention.
Do you have any questions?
I have a question.
Yes, ma'am.
So you mentioned the Wakefield article, and I think I'm much more familiar with the influence that it has maybe in the developed world or in the, kind of first world here. For example, Boulder, right? Where
Yeah.
you could pick out race and education categories probably where you're more likely to see vaccine hesitancy or refusal. Yeah. So what is the difference, or is it the same? What is the influence of that article in the developing world and vaccine hesitancy and success maybe?
Great question. Dr. Todd, who I think just retired, gave a great talk on vaccine hesitancy on the last meeting of the coalition in Colorado Springs in May. Edwin is just shaking his head on all this. My mind is working. And, it's definitely affected the United States. There's the story of the mother of the index case of the Disneyland outbreak. You all remember just a couple of years ago, the Disneyland outbreak? The mother was not an avid anti-vaxxer, and I don't know that she even knew of the Wakefield article, but she had a network of friends and exposure to information that she decided, well, I won't vaccinate. I'm gonna, I don't want to give risk to my child. Well, that her child was the index case of that outbreak. And she realized how sick her child was. Again, measles in Latin means miserable. And she afterwards formed her own NGO to work with mothers and fathers, parents, to promote and try to get them to vaccinate their children. Because we find in this hesitancy work, being a physician, a trusted provider helps, but peers also help. There is this peer, we want to fit in. And she is, I recall hearing that story. In the other countries, they're not as litigious as the United States, but it's there. I distinctly remember when I was at PAHO, director of the program, Peru was going to implement its measles rubella vaccination campaign, and a parliamentarian who was a physician stood up and cited the Wakefield and said, we're cause autism. They postponed the campaign because of that. There was a debate. So, make a long story short, 1 year later, how many CRS cases do you think occurred in that year in Peru? 10. 10 children affected. I mean, it's criminal, and because of that. So it does happen. It doesn't happen to the extent. Europe, Rob Butler is the director of the European WHO program, and he's actually a specialist in communication. He's not an epidemiologist, but it's fortunate for Europe because he brings a skill set to the European countries where the vaccine hesitancy is very strong, and almost, if not stronger, in some cases than the United States. Italy, in particular, France. And when you look at measles importations into the United States, into countries of Latin America, they generally come from the Germany, Spain, France. They're not coming from India. So, great question. It's not to the extent as Europe and the United States, but it is happening. I cited the Peru example to highlight that. Yes, Edwin.
John, a great overview as always. Let me sort of challenge you to sort of a thought, especially because we're in a group of epidemiology here. Traditionally, I see, the way that we have done epidemiology of vaccines has been looking at, the disease burden and trying to establish how it gets transmitted and risk factors. And then we go and basically vaccinate because we know that we have an effective vaccine. And then we move into programmatic measurements. I think the times of this age sort of are calling for a different kind of epidemiology. And I'm sort of wondering how much you think we should be moving from just outlining these overall risks that we traditionally do and moving into a more granular epidemiology that tells us how susceptible the population is becoming to a vaccine preventable disease, and how we can close those gaps. I mean, will that be better information for advocacy and use of vaccines?
So, good point. I showed data on the countries where polio and the numbers of unvaccinated children. It's interesting, in the measles rubella approach in Latin America and the Caribbean, you're right, the focus is on disease burden and traditional epi. But I'm going to cite an example where those estimates of susceptibility helped the program and actually defined every 4 years for follow-up campaigns, because Cyril felt that, and there was not strong evidence, but there was evidence to suggest that once the numbers of susceptibles for measles reached the birth cohort level, that the risk greatly increased. And that's when you want to do your campaign. You don't want to wait any longer. And I have examples of Argentina and other countries who waited, even with that analysis, 1 year later. They didn't do it in a timely fashion, and they had an outbreak during the time that they waited, when they should have been more urgent in their action. But it's an example where looking at the susceptibles and the potential benefits that could be linked to that analysis, I agree. Yeah, Susan.
And I had sort of a related question. I was just at a perinatal meeting of the American Academy of Pediatrics this weekend, talking about the virulence mutation in Zika virus that really predicts central nervous system effects. Would we ever take all the new knowledge that we have about virulence and about vectors and try to prevent an epidemic before it happens?
It's a great question. I serve on the board of the PERU Foundation USA, and it's chaired by David Heyman, who was once Assistant Director General of WHO, and he used to oversee emergency response. And I'm saying this because, as working as a board member, I've been to various partners looking at that question, because the PERU in Africa is about laboratory surveillance, diagnostics, positioning itself for future outbreaks. And there is a project, I'm trying to think of the acronym, and I'm going to guess it's PREDICT. It's funded largely by AID. A substantial amount goes to University California Davis Veterinary School in its One Health efforts to try to use genetic sequencing and other laboratory surveillance data that would predict when the next outbreak occurs. And it's a very interesting, exciting project. For me, grounded in the experience I shared, it's like going to the moon, where you're using this information to actually predict when the next Ebola or subsequent mutation, as you mentioned, of Zika is most likely to happen given these circumstances. So a lot of effort is going into it. A number of partners, including Bill and Melinda Gates, I think, has supported it, but largely financed and supported by USAID. Great question. Yes, sir.
So, you mentioned that OPVs are first choice.
For interrupting transmission.
Okay. I know there is a goal to phase out OPV by 2020.
Yes.
So what will happen to those 16 countries which have a high prevalence of polio? Would that undermine prevention efforts?
Great question. So I'll give you a short answer. So in the areas where there's still transmission, and even transmission of circulating vaccine-derived viruses, for those of you who don't know, that's when the OPV mutates back to almost wild form and causes outbreaks. It reacquires its ability to transmit and reacquires its ability to cause paralysis. That's circulating vaccine-derived viruses. There are outbreaks outside of the three, what people call the three endemic countries: Afghanistan, Pakistan, and Nigeria. So my answer is, in those three countries, it's very important to continue the OPV outside those countries and within them, but wherever this circulating vaccine-derived virus is, you use the OPV to stop that transmission. And then elsewhere, you accelerate efforts to transition to IPV. You have to protect the gains, and so it's a balancing act. But in the post-eradication world, we would not be using OPV, because eradication is not just wild virus eradication. It's the eradication of all polio viruses, including circulating vaccine-derived viruses, and including the vaccine, which can cause that, and the VAP I showed you. So you really want to make sure you're to that point, and then the whole world would be using IPV, hopefully for some limited period of time, not forever. But a lot of it depends on how the polio viruses are contained. With smallpox, there's still 2 remaining repositories, one in Moscow and one in the United States. So there's still that virus that could leak, bioterrorism. All those factors need to be assessed. But ideally, you would want to, we're not successful until we've reached an IPV approach to all children of the world. I hope, is that clear? Yeah.
Thank you.
Thank you.
Well, thank you very much. Again,
Thank you, Jill.
I think there's another class coming in, but thank you.
Yeah, thank you, Jill.